I want to welcome all of you to this webinar on behalf of the Substance Abuse and Mental Health Services Administration. In just a moment, I'll turn this over to Dr. Victor Schwartz from the JED Foundation, who SAMHSA is very pleased to be able to co-sponsor this webinar with, and he will be facilitating the webinar for us. I just wanted to say a few words about the importance of the issue we're going to be speaking about today. Everyone listening, I'm sure, is aware that the topic of suicide arouses anxiety in most people, including clinicians such as myself, because none of us want to make a mistake when someone's life is at stake. This anxiety is even magnified when a suicide cluster appears to be emerging. At these times, the anxiety can be palpable and pervasive, and the need for solid, safe, and prudent information is vital at such times. It is precisely because we don't have all the answers about how to prevent suicide clusters from happening that it is essential that we work together to share what we do know, including learning from the experiences of those in communities, in tribes, or in college campuses who have gone through this intense and difficult experience so that we all might learn and move forward together. So, again, on behalf of SAMHSA, thank you for signing up for this webinar, and we think it will be a very beneficial one for you to be participating in. And with that, I would like to introduce my colleague, Dr. Victor Schwartz from the JED Foundation.
Thanks so much, Richard. It's a pleasure to be here with you, and I really want to thank all of you at SAMHSA, you, Richard, and your team, and especially Jennifer Capello, who's done a tremendous amount of the work setting up this webinar and getting things organized, from really working along with us to get an incredible group of speakers to be here with you today. To really creating the platform and the structure for this webinar. So thanks to you and to your whole team at SAMHSA for the work you do and you know, for partnering with us in working with the 20 million or so college and university students in the United States. So just a couple of words of introduction, and we know that some people are having some challenges logging in, so we'll try to take a little bit of time, and that's why just an apology that we started a bit late, just to give people who are having some difficulties a chance to join us. But just a few comments about the agenda for the day. We have really two sections to the program. The first will run until approximately 3 o'clock or so. And then we'll have a 20 to 30-minute break, depending on how on time we continue to be, and then run again from 3:30 to 5. As you see, the first section of this webinar will be an overview of the epidemiology, the demographics, really what we know from a theoretical perspective about suicide clusters in general, what we know about the epidemiology and demographics of clusters on college campuses, and then we'll have a presentation about safe messaging and the media concerns around suicide and suicide clusters, and again, particular comments around the setting for campus. As you see, our first lineup of presenters are Dr. Madeline Gould, who is a professor of epidemiology and psychiatry at Columbia University and the New York State Psychiatric Institute, a good friend of SAMHSA and the JED Foundation, and a real leader in the field of suicide and suicide prevention, particularly in relation to young people. And our good friend Carrie Smith from the Suicide Prevention Resource Center. She'll be telling you a bit about that. She is the Senior Campus Prevention Specialist at SPRC and works closely with the schools who are in the Garrett Lee Smith Grant Program, which I think she may be talking about a little bit. And just to give you a sense of the lineup, after Maddie and Kerri do their presentations, we are going to have our second half of the afternoon presenters join us, and I'll introduce them in more detail, but this is Dr. Dolores Cimini, Dr. Greg Eells, and Dr. Phil Meilman. They'll be joining us for a 20 to 25-minute panel discussion among the presenters. And then we'll be leaving hopefully 20 to 30 minutes for Q&A from the audience. So the Q&A process is going to be all because of the size of the audience. We're going to be doing all of the Q&A through the website. If all of you would notice at the top of your screen there is an option that says Q&A. If you click on that and type your question, and then you can either click Ask or Enter, you'll be able to submit your question. We obviously won't be able to get all of the questions answered since we have quite a large audience today, but we'll try to cover as many as we can. And I see actually we have a question about accessing the PowerPoints. So just a reminder, we will be posting a audio and the PowerPoints from this presentation on the SPRC, SAMHSA, and JED Foundation websites after the closed captioning is completed. So again, the webinar contents will be accessible to anybody who wants to hear this down the road. They'll be on the 3 websites and potentially other places too. We're not sure. So again, just a reminder, the proceedings are being recorded. When people post questions and we use them, we're not going to be identifying the questioners just for everybody's privacy. And with that, I think we'd like to begin. And as I mentioned, our first speaker will be Dr. Madeline Gould, who will be giving us really a kind of theoretical overview of suicide clusters and what we know specifically about how and why suicide clusters occur on campus. So I'll now turn it over to Maddie. Thanks.
Okay, thanks. I'm delighted to be part of this webinar today, and welcome to everyone. Today, what I'll briefly start with is providing you with information on the scope of the problem, the estimated rates of college suicides, and then most of my presentation will focus on the, as Vic just mentioned, theoretical, but largely the empirical evidence for suicide contagion as well. Suicide is currently the second leading cause of death among college students, which I think much of the lay public isn't aware of how, the extent to which young students die by suicide. And those rates of completed suicide range between 6.5 to 7.5 per 100,000. This translates to about 1,500 young people on college campuses dying per year, assuming that there are 20 to 21 million students in college. That's about half the rate of a matched cohort from the general population. So although this is a very serious problem among college students, the rates of dying by suicide are actually even higher among young people, same age, who are not in college. When you look at attempted suicides, about 1% of undergraduates have reported that they've attempted suicide, and between 6 and 9% report that they've seriously considered suicide in the past year. Now, there are limitations to these estimates because college student suicide rates are not officially tracked by the Centers for Disease Control on a national level or from, the state departments of health and who keep the statistics. So that because they're not officially tracked, these estimates, the available rates are just estimates. They're based on some very good studies, but nevertheless they're estimates, and so that there is no national data firm data that's available on the numbers or rates of suicide clusters for certain, because without the data on the rates of suicide generally, there's no way to be able to identify whether clusters are occurring on colleges and university campuses. So what we know about that is usually from anecdotal reports, and that we can get a lot of useful information, and the folks who will be talking later on in this webinar, based on their experiences on how they had to cope with a cluster, have given us very, very valuable information. But on a nationwide basis, there's no information available on suicide clusters. And so that gives, it's a major challenge then to do research on suicide clusters on college, in college populations. I'll start with the definition of suicide contagion, or sometimes called modeling. And it's the process by which knowledge of one's suicide, and that knowledge can be direct, that someone actually knew that person who died by suicide, or it can be indirect. It can be through word of mouth, or it can be through media, but that knowledge facilitates the occurrence of another suicide. And that there are several mechanisms that have been hypothesized to be the basis for suicide contagion or modeling. These are not mutually exclusive. They probably do work together. I'm not going to be going into much detail about any one of them. If folks have questions, write them in and we can discuss it. But the mechanisms range from social learning theory, which has been very well established over so many different behaviors. Bandura was the first person to have been describing that. And I won't read through, you can read the slides, but I do want to just highlight the last one just a little bit, the emotional contagion, which is our ability to empathize with others, and that can make us prone then to mimicking or adopting other people's behavior, or even confusing other people's emotions with our own. The reason that I wanted to just highlight that a little bit, and not to say that that's the most important, but there was a very interesting example of emotional contagion by the, what's been called this now Facebook news feed experiment, which became quite infamous when it was published in 2014 because of different, consent issues that people were upset about. But that can be another question as well. For now, I just wanted to mention that for 1 week, that was in January of 2012, Facebook actually altered the number of positive and negative posts and news feeds to nearly 700,000 randomly selected users to see if it affected their behavior with regard to the tones of their posts that they then would subsequently send. And it turned out that the people who saw more positive posts responded by writing more positive posts. And those who saw more negative content wrote posts that had more negative content. And it showed in a very, very graphic way that emotions can be spread on social media. That was published in the National Academy of Sciences, the Proceedings of the National Academy of Sciences, for those who want to find that. But many of you, I'm sure, read about it in the popular press. And so with regard to empirical evidence for suicide contagion or modeling, it comes from 3 areas. The impact of studies that have examined the impact of exposure to a suicidal peer, research on the impact of the media, and research on suicide clusters. And that's what I'll be describing. So this is a summary slide of those studies that have examined the impact of exposure to a suicidal peer. There are about 20 or so studies now. And they've looked at the association between suicide attempts or deaths, but most of them have focused on suicide attempts by a peer, and then subsequent behaviors among friends, and that the majority of the studies have found a significant association OR stands for something that's called an odds ratio. It's very similar to what's called a relative risk, but it's a measure of increased risk. So that if someone in the peer group has attempted suicide or died by suicide, there's a 3 to 11 fold increase in the odds that this, friend will actually attempt suicide. So that clearly the impact of someone else in your either social network or a larger community, but by a peer, similar age, will increase an individual's risk of attempting suicide. Again, I'm going to be going quickly through much of this empirical evidence. So again, I welcome questions after our presentations. The research that has examined the impact of the media, there's many more studies that have looked at this now, now probably up to about 70 studies, and that the research finds that there is a significant association that you will get a greater increase in suicide under these conditions when the frequency of the stories increase. So there's clear evidence of a dose-response effect. The more stories that are reported on about suicide, the greater the likelihood that there'll be subsequent suicides. And I'm talking about completed suicides now. So a higher proportion of the population that's exposed, the greater increase in suicide. If the headlines are dramatic, if the stories are prominent, for example, if they're on the front page. And these are, the research has focused on stories that have covered non-fictional deaths. There's a little more equivocal evidence from stories that have focused on fictional stories or stories about, not real people. But the evidence from reports about real people who've died by suicide is really it's very consistent. It's conclusive in that conclusion that you will get subsequent, completed suicides under the conditions that are apt to influence somebody else's behavior. I'll be talking about the types of stories that might not have that negative effect in just a moment. In addition to finding an increase after suicides, there's also evidence that you can find a decrease in certain situations, and these converse effects. So there have been studies that have reported a decrease in suicides following the release of media recommendations or guidelines or during newspaper strikes, and that what has become a very influential study now is the study that has coined the term Papageno Effect, whereby there's a decrease in suicide following articles on suicidal individuals who've adopted positive coping strategies and actually have refrained from suicidal behavior in adverse circumstances. So there had been something that had been coined as the Werther Effect, and those were the studies that I reported on or summarized in my past slide, whereby you get an increase in suicide following suicide stories. That's the Werther Effect, and that was based on the Sorrows of Young Werther that was written by Goethe, and that after that publication, there were a whole slew of people who were mimicking that death. But in contrast now, there's something it is this Papageno Effect, and it's based on the work by Thomas Nieder-Krotenthaler, who's at the University of Vienna, and I have the good fortune of collaborating with on a few different studies. He published this work, one of many now studies that he's published, in 2010, which was a content analysis of nearly 500 suicide-related print media reports that were published in Austria in their 11 largest nationwide newspapers. And he had anticipated that he would find an increase in suicides, in the, communities that had access to the newspaper stories, and he did find that if the stories were repeated and under certain circumstances. But what he also found was in those studies where the person that the article was about, instead of succumbing to suicidal behavior, actually adopted, helpful coping strategies in light of their suicidal behavior. That in the communities that then where these stories were published, there was a significant decrease in the rates of completed suicide. So Thomas had coined the term Papageno Effect based on an opera by Mozart, The Magic Flute, where the character, instead of succumbing to suicide, these imps, fairies and various things, give him strategies to say, no, don't die by suicide, and he indeed doesn't go on to engage in suicidal behavior, and that's where the term now has gained a lot of speed. In this next slide, I want to show you how the evidence of, at least in Vienna, they have called it media guidelines. In the U.S., we've talked about media recommendations that Kerri is going to be elaborating on. And you can see that there was a very, very dramatic decrease in rates in the number of suicides. These were suicides that occurred in the Vienna subway system because that was the most prevalent means of dying by suicide in Vienna, and the media guidelines specifically targeted subway system suicides, and there was a 75% decrease after the publication and the dissemination of these media recommendations. I now want to move on to the evidence that we have about suicide clusters, and the other speakers, later on will discuss their experiences that they've had on their college campuses with how they've had to cope with suicide clusters. And this headline, unfortunately a very dramatic headline, not something that we would have recommended being reported in this way, but very dramatically defines what we mean by a suicide cluster. Here it was a sixth in a string of, in this case, fatal flaws, and that the definition, you can also see, unfortunately, that they've included in this article the actual names of the young people who died by suicide and how they died by suicide. What we mean by a suicide cluster is an excessive number of suicides occurring in a close time proximity and/or close space proximity. And that there have been a number of different studies. What I've called the first generation, second generation, and third generation are what started off with descriptive anecdotal reports and just sort of descriptions of, what is this? What's going on here? And then another series of studies that have asked, is it really a cluster? Does it meet criteria for being a statistical, significant, statistically occurring cluster? And then a third generation, not many studies, but of trying to examine, well, why? Why are they occurring? And so I won't list all of the anecdotal reports that have been reported, but I do want to at least summarize some of our own work that looked at, are suicide clusters occurring to the extent that it's actually statistically significant. And I won't go into all this detail. I will say that, we looked at suicides across the age span, and I just want you to focus on the highlighted conclusion that clusters occur primarily among teenagers and young adults. That when you look at other ages, they may sporadically occur, but not at a rate that would be considered, a public health problem, or above what you might expect by chance. But among teenagers and young adults, it is a public health problem, and it is occurring beyond what you'd expect by chance. And so in a psychological autopsy study that we did of cluster suicides in adolescents that was funded by the National Institute of Mental Health as well as the American Foundation for Suicide Prevention, we wanted to examine, well, why is it that you can get suicides in this case, it was actually 53 communities, and so you get a suicide in a community, and then there are other young people who died by suicide following that first suicide. But in other communities where suicide occurs, you don't get additional suicides. And so we identified 53 clusters in the U.S. There were certain states out west that didn't agree to participate, which is why some of them don't have clusters listed on my map. And that the definition that we used was a significant excess of suicides found statistically that it was within a town or city of residence or occurrence. So that, we know that some college students, may die in a place that's not their official residence if they are, in school and their official residence is at their parents. These are, for our study, it had to be in a significant excess within a 3-month period, and it was limited to communities less than 500,000, which at that point was just New York, Chicago, and Los Angeles for statistical reasons. Again, if you have questions, we can talk about it. But I do want to emphasize that for practical purposes, this is not a definition I would use. For a study, it's fine. But in work that I had done with the CDC, back in the early 1990s, our definition of a cluster was if the community thinks it's a cluster, then for all intents and purposes, the public health and mental health professionals have to react as if it is a cluster. But for research, you have to have a more rigorous definition. In that our clusters ranged in size from 3 to all the way up to, actually 11. We had a match sample of controls. These were also young people who died by suicide because we wanted to know why, as I mentioned before, do you have a death by suicide that doesn't lead to a cluster, yet another death by suicide that does. So that they were matched on the date of death and so on. They had to be in the same state. The population sizes were similar. They had to be the SMA, which is whether or not they were in a metropolitan area. They had to be within the same age range. And that we received, we did a psychological autopsy by interviewing parents and peers, getting coroner's reports, police records, census data. Today I'm going to focus on the information that we've published on our newspaper review that was published last year in Lancet Psychiatry, and it specifically was addressing the question, does the media play a role in triggering a cluster? And so it was a national population-based sample of clusters. We had, again, as I mentioned, the matched sample of non-cluster suicides in communities. Very, very comprehensive identification of newspapers in each community. We had conducted content analyses of, over 1,700 stories that occurred in these communities, looked at a number of confounding factors. I'm just going to briefly summarize the results so that we can get to the remaining speakers as well. That in comparing the stories that occurred between the first person who died in a cluster and the second death, so that point at which a suicide started to be initiated, and taking that same, let's say, length of time, if there was, let's say, 10 days between the first young person to die in a cluster and the second to die in the cluster, then we would take 10 days for that matched community and look at 10 days worth of newspaper stories. If there had been 3 weeks or 4 weeks between a first death and a subsequent death, then we would take that length of time in the matched community. If there were 2 days, then we'd look at 2 days. And what we found by doing a content analysis of all those stories is that there was a significant increase in the number of stories following the first person to die in what then became a suicide cluster. So if you get that first death by suicide, and you have a lot of suicide stories about any suicidal individual, then it's more apt to then trigger a suicide cluster. We also found, a significant number of stories about that actual first suicide and other teen suicides as well, and that would increase the likelihood of a suicide being triggered. The characteristics of the stories that were associated with the triggering of a suicide cluster was the story being on the front page, the size of the headlines being bigger, there were more stories with headlines containing the word suicide, and that's going to come up in some other people's presentations. You'd have more stories with headlines containing description of the methods. That's also going to be coming up again. More sensational headlines, more pictures, and more detailed descriptions of suicidal individual and the actual act of suicide, so that there were clear characteristics of the stories that were associated with the triggering of of suicide clusters. So I just have a couple of more slides, and then I'll be done. I just wanted to summarize the magnitude of the effect. I'm saying that there is a significant effect, but again, I want to say, well, how big effect is that? We know that from those the research studies that I summarized with regard to the exposure of a suicidal peer, that the increased risk seems to go from 3 to about 11 times, greater odds of engaging in attempted suicide if you've been exposed. That, just to give you an idea of the impact of the media, there was a 12% increase in suicides shortly following Marilyn Monroe's death. We saw that 75% decrease in subway suicides following the implementation of media guidelines. And that with regard to suicide clusters, again, I want to emphasize there's no national data other than really some of the work that we've done to give you estimates of suicide clusters, but our best estimates is that it's actually relatively rare. It's between 1 and 5% of teen suicides. This doesn't include college-aged suicide, so that you probably would be doubling these rates if you included them. So I just want to end, well, actually here in the, sorry, one last slide, but just to put suicide clusters in context of really the many risk factors that influence suicidal behavior. That, suicidal behavior doesn't occur in a vacuum. There has to be some underlying vulnerability. These are from psychological autopsy studies and many other, other types of studies. A stress event occurs that exacerbates some underlying vulnerability, or sometimes the underlying problem may cause the stress event if someone is, irritable, that it causes acute mood change. And that's where now Contagion and the media can play a role in that once you have a recent example, either, again, direct or indirectly, it may facilitate this very vulnerable person's, engaging in suicidal behavior. But luckily, with media models of coping, that young person won't engage in suicidal behavior. So now I really am ending, and so in conclusion, that given the prevalence of suicide on college campuses and the associated risk of contagion and clustering that we know is real, that it's imperative that colleges develop effective and comprehensive postvention strategies, and luckily many of our, the speakers today will be talking about the postvention strategies that they put in place. So thank you for taking the time to listen, and now I'll move on to Carrie Smith.
Thanks so much, Maddie. That was a really great overview of the theoretical concerns around suicide and suicide clusters and contagion. We're now going to move on to Carrie Smith, who, as I mentioned before, is a senior campus prevention specialist at the Suicide Prevention Resource Center, who works with many, many colleges around their suicide prevention and mental health programming. Kerri is going to go into more detail of some of the things that Maddie covered in discussing really what what should we be doing and not doing around reporting and media coverage of suicides and suicidal behavior? So I'll now turn the presentation over to Carrie Smith.
Great. Thanks, Vic. I also wanted to echo Maddie. Thank you for doing such a wonderful job of laying out the issue of suicide clusters and suicide contagion. So I'm really delighted to be joining you all today. So for those of you who aren't familiar with SPRC, we're established in 2002 and are funded federally through SAMHSA. SPRC provides prevention support and serves as a resource destination for anyone who's looking to find out more about suicide prevention. And as Vic mentioned, my primary role is to provide training and technical assistance to colleges and universities that have gotten Garrett Lee Smith suicide prevention funding through SAMHSA, but we also provide assistance to a wide range of populations from other campuses, local community organizations, statewide agencies, and tribal nations. In the interest of time, I won't go over all of the resources we have available, but after today's webinar, I hope you'll take a few moments to take a look at our website, sprc.org, and explore some of the resources we have, including a searchable online library, free online courses, and a portion of our website that's dedicated to campus suicide prevention. I also did want to mention that SPRC serves as the Secretariat to the National Action Alliance for Suicide Prevention, which is a public-private partnership that's dedicated to advancing the national strategy for suicide prevention. I wanted to highlight this because we're going to be spending a little bit of time today discussing a resource that was developed by the Action Alliance. So in my portion of today's webinar, we'll spend a little bit more time examining the issue of how we communicate about suicide deaths and steps you can take to communicate safely and effectively in the event of a death on your campus. I'm also going to spend a little bit of time talking about how you can work with the media, both on and off campus, to ensure that news about the death or deaths is reported in as safe and as helpful of a way as you can manage. And then I'll also talk a little bit about how to address communications over social media platforms. I should note here that communications is just one part of an overall comprehensive post-vention response after a suicide death, and my other colleagues that are on the webinar, especially those in Part 2, will be able to cover some of those other considerations. And as Victor mentioned, we also will have some time after my presentation to answer any questions you have, so please feel free to type in your questions in that Q&A tab at the top of your screen, and we'll get to those after my presentation. So as Maddie mentioned, she did a really great job of laying out the research of how the media can influence suicide contagion, but I'm betting that most of you are not from the media. So I think it's important to first point out here that safe messaging concerns are not focused solely on the media. How we in the suicide prevention field, campus administrators, and other campus staff communicate about suicide could also potentially influence those who are at increased risk of suicide. It's also equally important to recognize that using unsafe messages or focusing too heavily on how big of a problem suicide is can undermine our prevention efforts by reinforcing stereotypes or making it seem like suicide is too big of a problem for us to solve. So how do we communicate safely about suicide? The National Action Alliance for Suicide Prevention created a comprehensive resource to help guide suicide prevention communications planning. The framework for successful messaging can be used to help develop any communications about suicide, not just communications about a suicide death. This slide includes an image of that framework model, and as you can see, safety is one of those main 4 components. And I've also included a link to the framework on this slide so that you have it. Okay, so let's dive a little bit deeper into the guidelines about talking safely about suicide. So here is a list of the don'ts for messaging that are outlined in the framework. And these guidelines are meant for anyone who's going to be communicating publicly about suicide. And as Maddie mentioned, there are guidelines specifically meant for the media, and we're going to talk about those a little bit later in the presentation. So let's walk through these guidelines. When communicating about suicide, we want to avoid showing or explicitly describing suicide methods or locations where someone has died by suicide. As Maddie mentioned, pictures or detailed descriptions of how or where a person died by suicide can encourage imitation and serve as a how-to guide. We also want to avoid including personal details of people who have died by suicide. Vulnerable individuals may identify with the personal details of someone who died by suicide, which could encourage them to end their own lives as well. We also don't want to glorify or romanticize suicide. Portraying suicide as heroic or romantic or honorable acts may encourage vulnerable people to view it more positively and lead them to also seek out the attention garnered by someone who has died by suicide. And a common issue that you'll often see in news articles or other communications materials about suicide is it being normalized or portrayed as a common occurrence. So when we're communicating about suicide, we want to walk a fine balance of not minimizing the problem of suicide, but also at the same time, we don't want to imply that suicidal behavior is acceptable, normal, or what most people would do in a given circumstance. I think we all know that the vast majority of people who face adversity, live with mental illness, or face other challenges, even those in high-risk groups, do not die by suicide and instead find the support and treatment and other ways to cope. And as Maddie mentioned with the media research, these are really the messages that we want to focus on instead. And similarly, we don't want to use data or language that suggests suicide is inevitable or unsolvable. So describing suicide as an epidemic or using terms like bullycide, which could imply that someone who is bullied will inevitably attempt suicide, may make suicide seem too overwhelming to address. And along these lines, we want to avoid providing extensive statistics about suicide to the public without at least also including solutions or action steps that reinforce that suicide is preventable. In addition to this, we want to make sure that we don't portray suicide as being an overly common or unsolvable event. We also want to avoid oversimplifying the causes of suicide. So we know that suicide is complex and it often is a result of a variety of risk factors. So therefore, we should avoid attributing suicide to a single cause or circumstance, such as a breakup or bullying, high stress at school, or being from a particular high-risk population. And we should also avoid portraying suicide as having no cause whatsoever. So in this case, we mean describing suicide as an inexplicable act from an otherwise healthy or high-achieving person, because this may encourage identification with that person who died, or again convey that suicide is something that can't be prevented. And more importantly, also, this language is a missed opportunity to educate the public about warning signs and how we can respond to them. And lastly, we should avoid reinforcing negative stereotypes, myths, or stigma related to mental illness or suicide. This sometimes can feel like it's easier said than done, but we'll talk about how you can kind of avoid some of that. So some examples of this is messages that link particular groups with high rates of suicide or mental illness, especially without examples of effective interventions or stories of recovery. So an example of this would be focusing heavily on talking about suicide in veterans in a way that makes it seem that all veterans will attempt suicide. Also making broad statements such as breaking the stigma of mental illness or other similar language that reiterates the extent to which stigma is a problem. This actually can serve to reinforce stigma rather than counteract it. And lastly, using adjectives like successful suicide, unsuccessful suicide, and failed attempt can make it seem like a suicide death is defined as a success and that a non-fatal attempt is a failure. Additionally, terms such as committed suicide are also problematic because the term committed is often associated with crimes. So using this language can reinforce stigmatizing attitudes about people who die by suicide. So instead, it's better to use language such as died by suicide or completed suicide. So to illustrate some of these safe messaging don'ts, let's go through some mock newspaper headlines and see what you feel might be unsafe. So I just made up these headlines, but I'm sure you all have seen similar headlines before. So just take one moment and look at these and consider what may be unsafe here. So the first headline, I think probably after Maddie's discussion, you might recognize what's not okay here. This is an explicit discussion of means, so that could influence those to also try that particular means of suicide. That second headline where it states, gay college student bullied to death, that phrase bullied to death oversimplifies the reasons why someone may attempt suicide. And as we talked about, suicide is complex, and saying one thing is to blame for their death really ignores the constellation of risk factors that likely influence their decision to attempt suicide. And then that last headline, university president working to stop suicide epidemic on campus. Using the word epidemic on campus can make it seem like a common event that we may not have a solution to. And as we talked about just a moment ago, focusing on how big the problem of suicide is also misses the opportunity to share those stories of hope, recovery, and resilience, and how people can help those who are struggling with suicide that the research that Maddie mentioned shows can actually be protective. So, and while these examples are media headlines, I'm sure you can see how some of the language can creep into our prevention messages and communications after a suicide death. So you're probably wondering, after seeing this long list of don'ts, how you should talk about suicide, especially after you experience a death on campus. And I wanted to show you some real examples of how we can communicate safely about suicide and mental health in a positive way. And these are headlines that aren't specifically related to postvention, but I think it's helpful to see that compelling news stories can be created without unsafe or sensationalized language. And that also holds true for our prevention communications. And many safety issues occur when messages focus on the problem of suicide rather than what can be done about it. So the framework for successful messaging includes a section on conveying a positive narrative about suicide, which in essence is just shifting our communications away from the problem of suicide and instead conveying concrete steps people can take to help themselves or others at risk for suicide, while also highlighting effective treatments and stories of recovery. So I wanted to switch gears here after we've gone over those do's and don'ts and talk a little bit about planning steps you can take now so that you can maximize your communications if a suicide death or deaths occur on your campus. It's always helpful to develop your postvention response prior to a death because I think we all can attest that it's much more difficult to do good strategic work in the middle of a crisis. And also dealing with multiple suicide deaths, I think it's especially important to be able to move quickly and provide clear, accurate, and supportive information as quickly as possible before rumors and inaccurate reports of events start to circulate. So one of the major areas you're going to want to think about is the policies that you should have in place around communications about a suicide death or deaths if one was to occur. So this slide includes a few questions that are helpful to think through. Often it makes sense to identify one person, whether that's your Dean of Students, your VP of Student Affairs, your college president, or some other person to communicate about the death to the campus community. You'll also want to identify the best method to do this, whether this is in an email or some other form of communication. And if you're part of a large university, you may also want to decide if that announcement should go to the entire university or just the school or college that the student was enrolled in. We've seen that some schools also decide to send separate announcements to faculty and staff that give guidance on how to respond to students who may request extensions on projects or have absences to attend memorial services, as well as resources for Res Life staff for how to talk about the deaths with students living in the residence hall. In addition to that broad announcement, you may also want to consider having your Dean of Students, Counseling Center Director, or representative that you identified for that campus-wide communication to also provide a more personal, maybe even face-to-face announcement with friends or close classmates of that deceased student. It's also good to spend a little bit of time thinking about the actual content that would be shared within these announcements. So the information that will be included will likely be influenced by what is known about the death, the family's wishes, and the time of year. So if the death happens during the summer or some other break, it might look different. But it is still helpful to create a template ahead of time that can be used in the event of a death, and then it can just be tailored to the situation. So this will allow you to also get information out more quickly and thoughtfully. And HEMA, the Higher Ed Mental Health Alliance, created a really great postvention guide that's included in the resources for this webinar that includes a sample general announcement letter that you can work off of. And again, while the information shared will vary by situation, you'll want to at least include condolences to family and friends, a description of what the school will be doing to support those grieving the loss, and any changes to class or work schedules if applicable. And I think my colleagues on this webinar can share some of their thoughts about addressing family wishes later on. But if the family does not want to publicly acknowledge the death, a good first step is to explain to them why it's helpful to share that it was a suicide death. So by letting them know that you can better address the needs of friends and other students who might be impacted by the death or be potentially at risk, as Maddie's research showed. And that there's also likely rumors already swirling around, and this will help you provide more accurate information and kind of get ahead of those rumors. If they still don't want the information shared, it's probably best to announce it as the sudden death and frame any mention of resources available as grief resources that you would offer during any death. There's probably already, as we said, speculation that the death was a suicide, so you can certainly consider including suicide prevention resources and talk about suicide with students as part of your overall grief resources. So you don't have to completely avoid the topic of suicide if the family is unwilling to publicly announce that. You're also going to want to work through who will be designated to talk with the media. Often this would be someone out of your public relations or media office, as well as possibly select senior administrators or counseling center leadership. And all of these folks who are designated contacts should be briefed on sample talking points and the safe messaging guidelines that we just talked about. So I think we've already established that working with the media can be challenging sometimes, especially in the wake of several suicide deaths. And I know that Dolores and others on the webinar can share some of their experiences with the media overstepping their bounds or writing sensationalized, unsafe stories. So this is why it's especially important to come up with policies and protocols ahead of time that designate specific media contacts after suicide. And you're really going to want to stick to those protocols that you determine when a crisis occurs. So while you can't choose which reporter is going to write a story about your school, it can help to establish relationships with your local newspaper and any reporters who focus specifically on health or mental health reporting. This also goes for on-campus media as well. And once you establish those relationships with your local news outlets, it can help to also provide informational packets to reporters that include the safe reporting guidelines, resources for suicide survivors, sample language to include at the end of any mental health stories that includes the National Suicide Prevention lifeline number, and information about your mental health promotion and suicide prevention efforts. Doing this before a crisis occurs, one, will hopefully get them to focus a bit more on what you're going to be doing to respond to the suicide death or deaths, but it may even prompt them to write a positive story about your work before a suicide crisis occurs. And you also will want to be prepared to respond if someone from the media reports on a suicide in a way that's not safe. So this may mean contacting the reporter to let them know what was unsafe about their story, or even writing an op-ed or letter to the editor to help reframe the issue. Especially for student reporters, your guidance on how to help reduce the risk of contagion can provide a really valuable learning experience that I personally hope that they'll carry on for their future reporting when they're out in the field. And I've also heard of several schools where mental health promotion staff have established relationships with their communication schools so that communication students receive training on safe reporting in their classes so that they're getting that information before they hit the ground. So we've talked a lot about those reporting guidelines. For reporters, this is a link and screenshot of the recommendations for reporting on suicide for the media. This was a consensus document that was created in conjunction with SPRC, SAMHSA, and several other organizations, and it provides just a nice, succinct two-page list of do's and don'ts that you can provide the media or student media to hopefully help them create safer stories. And also, I don't think I have to tell you all that social media plays a large role in the lives of college students. Information can travel really quickly on Instagram, Facebook, Twitter, and all the other platforms that it's often hard to keep track of which ones are so popular now. So it's really helpful to have a plan in place ahead of time for how you want to include social media in your postvention response. So this may mean posting information about services available, monitoring to see if comments are made, indicate a need for outreach to particular students, and also combating any of the unsafe messaging you might see in posts. And oftentimes students will have privacy settings that may prevent you from seeing information on their pages. So you'll need to work with friends and families to monitor the deceased student's page or to look out on other pages to see if something is unsafe. And also several media platforms, including Instagram, Facebook, and Twitter, now have guidelines in place for reporting concerning content. So you may want to familiarize yourself with this process and educate others who may be monitoring the pages. So I know it can seem daunting to include social media in your postvention planning, but there are some resources out there for you. The National Suicide Prevention Lifeline has a really great online postvention manual that includes sample language that you can use for posts and responding to concerning posts. All of these are included in the resources for this webinar. Also, on this slide, you can see the information that Facebook provides for how to respond to a friend that you're concerned about or how to report concerning content. And then the JED Foundation, Facebook, Instagram, and the Clinton Foundation created a really great guide for teens or young adults for what to look out for in terms of concerning content from their peers and how you can respond to that. So there's also those resources that you can rely on as well. And with that, I am going to conclude my part of the presentation, and I look forward to hearing questions from you all.
Thanks so much, Kerri. That was a very thorough and clear review of the subject of media and social media and reporting around suicide and safe messaging. So we're now at about 2:35, and we did get started a bit late, but just as a reminder to those of you who are listening in, what we're going to do now is ask the presenters from part 2 of this presentation to just make a couple of comments and responses and thoughts, and maybe get about a 10-minute conversation going on, and then hopefully leave ourselves about 15 minutes or so. I suppose we can probably run till about 3:05 or 3:10 with Q&A. Just as a reminder, if you'd like to post a question, I see some of you have been posting questions into the question box. Go up to the Q&A bar on the top of the page, enter the content of your question, and either press enter on your keyboard or ask on the Q&A box. And we will hopefully get to as many of your questions as we can. But now I'd like to ask Dolores, Greg, and Phil to respond and share any thoughts or comments they might have had in response to the first section of our presentation.
Yeah, I'll start. This is Greg from Cornell. Yeah, I would just say that everything that has been talked about is just a great foundational kind of guideline for when you have these type of clusters on our campus. I mean, we were fortunate enough when we had a series of 6 suicides within a single year to have Madeline with 2 other colleagues, Eric Kane and Kerri Knox, come and talk to us about some of these issues. And, you know, one of the things that really hasn't come up around this, around clusters, is around means restriction, which I'll talk more about in my part of the presentation. But I think the method of the completed suicides also really changes how you have to talk about some of these things. And I think it really is a challenging issue. And even though there are broad general guidelines that we, as Kerri said, we need to think out, each one of these is going to be different. And there are going to be a lot of different ways in which it impacts the community. And kind of the high-profile, visible deaths, some that we've had at Cornell, some that, like the one that's been picked up in the media at Penn from parking garages, they do impact the community differently and have a way of impacting how clusters can develop, and I think have some unique ways that really require you to respond.
Dolores or Phil?
Sure. I'll chime in at this point. This is Dolores Cimini from the University at Albany, and I would also concur that the information that's provided on this webinar really resonates with our particular experience at the University at Albany. On part 2, you'll hear about the cluster suicides that we experienced in 2011 in the spring. And one of the things that really came to light for us is, even though there are very clear guidelines and lots of resources to help us, every single suicide that can occur in a cluster, or student death for that matter, even if it's not by suicide, exists in a context, and it's really important to look at the system, how the student body reacts, what the policy implications are, and also really look at what's going on through the lens of cultural competence. The suicides that we experienced were of students from very different cultures, and I'll talk about that in more detail, but just want to put the idea of cultural competence as a backdrop in our discussions from further on.
This is Phil Meilman from Georgetown, and I want to very much agree with Greg that this is great foundational information. It's very important. I think the question of messaging in the media is critical. And one piece that I'd like to emphasize here is working with student media. The time to have the conversation about how to report a suicide is not right after the suicide occurs on a campus. I think it's at the beginning of the year where you call together the editors of the campus media, the student media, and you have a conversation with them, and you present some of the information that we just saw on the screen here today. This way they're prepared so that when or if the worst happens, they have some background on what to write in their stories and what not to write. So I think you want to do some prevention, if you will, with the media. The other thing I want to say is that postvention is very important, and I'll be talking about that in the second part of this webinar. postvention, in other words, what you do after the fact, to me, is prevention, because in the wake of suicide, anyone who's ever had a suicidal thought tends to revisit it. And it's very important to have postvention going on so that those thoughts don't mature into something actionable. And we'll be talking about that a little bit later. The last piece that I want to mention is that if you, and this will come up in my part of the presentation, that the messages you may give in a small group meeting would be very different than what would appear in the press. And because oftentimes with postventions, you're working with people who know the person well, who knew the circumstances well. I heard reference in some of the discussion today to the rumor mill. The rumor mill runs rampant in the aftermath of a suicide, and getting people good information, those who are knowledgeable of the person in a first-hand way, I think dispelling myths and rumors is very important. But that's on a more personal basis, not in terms of media. So we'll get to that later this afternoon.
Right. Thanks so much to all of you. And what I'd like to do now is maybe begin to just weave in some of the questions that are coming from our listeners. Please continue to write in your questions. We'll try to get to as many as we can, and we will be sharing them with our panelists. So the first one is actually a specific question. Someone wanted to know, Maddie, what you had on your slide of theories, what approach avoidance conflict means.
Oh, okay, good. And, you know, any questions that folks have, because I went through it very quickly. So by approach avoidance, what it really meant was that there was a pre-existing thoughts about suicide, or that they've already been approaching, that there's a conflict that already exists within a person, so that someone may have had suicidal ideation before, you know, have a number of the different factors that I had in that other slide that listed vulnerabilities, but that they were approaching, you know, being drawn to suicidal behavior, but then at the same time avoiding it. And so that there are many problematic behaviors that have that tension of sort of wanting to do something but not wanting to do something. And there's some equilibrium then that is then found within that person. And then in the context of someone else's suicide, it gets unbalanced. That all of a sudden it gives more motivation to be approaching that, you know, behavior that they really are trying not to, but that there's some pre-existing conflict that exists. So it's another way of conceptualizing that vulnerability or pre-existing factors that may have made that person be thinking about suicidal behavior. And that, again, that there's a pre-existing conflict, but they're managing to keep things on the side of, you know, not engaging that behavior. You could think of it as a, you know, as a weight, as a scale. And all of a sudden, someone else's behavior gets them to start perhaps ruminating about suicidal behavior more, and then just tips that balance, unfortunately, on the, you know, towards engaging in the behavior. So that's what that meant.
Thanks. So a question has come from the audience about, and this is maybe part of a broader question about why is it that contagions and clusters are more common in the adolescent and young adult age group, and the question, I guess part B is, do we have any evidence that this communicability or contagion of emotions is more likely to happen among young people than just people in general?
Yeah. So I'm assuming that's for me too. That's Maddie.
Well, anyone.
Oh, I guess it could be anybody.
That's to chime in, but Maddie, why don't you start?
I'll at least start with that. Right. I think that there are two things. You know, we don't definitively know why, but these are two things that we, you know, that many people have considered. Number one is the nature of peer relationships as people move into adolescence and young adulthood changes. Younger, kids are much more involved in the family, and then they, puberty hits and so on, and then their connectedness, their peer connectedness really gets to be enhanced, and they really are just much more involved in a peer community. Then they get older and get married or have a significant other and perhaps have children and so on, and then the focus again is on immediate family. But during that time period of adolescence and young adulthood, which is the ages that we saw in our examination of mortality data to be the ages where clusters and contagion were much more significant, I think is really influenced by that peer connectedness. Another factor might be, the neurobiology of young people, in that, we know that they're, whether they want to accept this as a reality, but that, cognitive or executive parts, control parts of the brain, the prefrontal cortex, and so on, it's just not fully developed in adolescence and even young adulthood. And so inhibitory control of behavior is not quite the same as when they will, a few years later, and so that they might be more impulsive. That might, in the way that they don't inhibit other inappropriate or impulsive behaviors, they may not have quite the same ability to have that, what people have described as a braking system. So it's probably both social and, biological reasons that may, underlie the reason that it's, contagion is mainly among teenagers and young adults, and that there seems to be evidence from, the impact, the studies that have looked at the impact of the media generally, not in a, cluster situation as well, that have also reported a great, can be across the age span, but a greater susceptibility among teenagers and young adults. And when you think about certain fads and shoes and, various things that have nothing to do with suicide but social behavior, you can start to really, understand why, other behaviors in general seem to be more, quote, contagious in, among teenagers and young adults.
Anybody else like to?
This is Richard McKeon. I just wanted to add one other point. I think Dr. Gould has given an excellent summary of why suicide clusters are more common among adolescents and young adults. I would just point out that the phenomenon is not completely unknown among adults. So, for example, Ella Aronsman, who's an internationally recognized suicide prevention researcher at the University of Cork in Ireland, has done work regarding a suicide cluster among men in middle-aged men in a rural community of Ireland. So just, I think that's kind of an important caveat. So even on a college campus, we wouldn't want to think that it's only the young people who might be vulnerable, and there might not be, for example, perhaps a faculty member who was really struggling before a suicide cluster began to emerge, who might not be influenced by what was experienced around them. So that would be just a small caveat I would add.
I think that's a really important point, Richard. And there's an irony here that we know that one of the social issues that's protective against suicide is social cohesiveness, or the tightness of social ties. And there is this irony, while social cohesiveness is probably, is certainly protective, there also seems to be the potential for risk. We know that young people tend to create, intense and sometimes very quick social connections and this can be a great source of support, but it, in other circumstances, can be a source of risk as well. We have an interesting question.
Oh, may I just, may I just wanted to highlight.
Yeah, sure.
I'm glad, Richard, that you mentioned this, because we do know of situations in schools where teachers have been involved as well. And so clearly, you know, the strains that and the pre-existing vulnerabilities, you know, among adults have to be taken into account when a cluster occurs. And that we know that clusters are occurring in military units as well. They tend to be younger, so you may, you know, they are adolescents and young adults. It's not the adults, but you know, it's the clusters are going beyond just the communities that we're talking about today. Yeah.
Right. Thanks. Do we have any information? We have a question from the audience about whether the obviously highly reported death of Robin Williams last summer had any impact on rates of suicide in the United States or in particular communities?
You know, we don't know yet if it had an impact on rates of suicide. You know, the mortality data isn't available yet. It's usually available a couple of years, you know, after the year. But we do know that the rates, and in fact, I think Richard was part of that publication with John Draper from the National Suicide Prevention Lifeline, that, and I think it was in the CDC morbidity and mortality report from what I remember, but Richard probably, you know, would know better, that the rates of calling the National Suicide Prevention Lifeline went up, which is, you know, could be considered a good thing, you know, and I think it's because the messaging, although some of the messaging was really not what we would have recommended, some other messaging was actually very useful after Robin Williams' death with regard to accessing care via, specifically in this case, the National Suicide Prevention Lifeline. And so that very dramatic increase in the rate of calls after his death shows how when you do share, you know, resources of, you know, for help, that, you know, folks who are worried about their suicidal thoughts, you know, then have a positive way to, you know, to deal with it. So we do know that those rates went up. In terms of undesirable rates, we don't know yet.
And another question, and maybe Kerri, you can address this in some of the work you've had with you know, a number of the GLS campuses. Are there problems related to underreporting of campus deaths or suicides? I mean, one of the issues that has anecdotally emerged is that sometimes when there's a delay or when there's no reporting at all, but you know, other than around the kind of social media and rumor mill, actually there are suggestions that it might increase anxiety among the students on a campus.
Mm-hmm. Yeah, that's a really interesting question. I think certainly that is where it's important to try to communicate what you do know, even if you're not really able to communicate very much, and start providing some post-vention grief support as soon as possible so that it doesn't look inadvertently like the school is covering something up or trying to avoid talking about something. I think UPenn had to deal with some of that in their suicides that happened in recent years. So really, I think this is, again, points to the need to kind of get on top of announcing as much as you can within reason and starting your services to suicide survivors as soon as possible. And I'm sure my other colleagues on the webinar today can also share a little bit about their own on-the-ground experiences.
Yeah, I would just, this is Greg again. I would just like to reiterate that I think a key concept around this is transparency. I mean, your philosophy as an institution has to be as transparent as possible. And there are always going to be complexities with families, with the nature of the suicide. You know, for us, especially with suicides that were high profile, we made a very conscious decision in consultation with people like Maddie and other folks to say, you know, this is a likely suicide, to really comply with all the things that have been talked about earlier, but really come from that transparency position, taking into account what's going on with the families and some other things. And in all honesty, the suicides are different. If the clusters are occurring in much less public ways, there's going to be a different public response, and sometimes transparency is often harder to balance with the wishes of the family or even getting a final ruling on whether a death was a suicide or not. So I think some of those things bring in additional complexity, but that seeing this as transparency is really being where you're coming from, I think, is essential.
I think that's a very important point.
Vic, I'm sorry. May I just,
yeah,
this
go
is
ahead.
Jen there. You bring up something that I then want to highlight based on what you're saying, that, clearly from today's, webinar, and, we're saying that suicide contagion is real and exists. But I've then heard people say, in terms of you talking about underreporting, but I've heard mental health professionals in the past say, well, you know what, then they're reluctant to even ask about suicide. Because suicide contagion exists, they're afraid to ask about suicide for fear that, we'll put ideas into people's heads and so on. And so, I think we all will absolutely agree that you need to ask about suicide.
You definitely do. I mean, you have to dispel it.
You have to, exactly. And so that even though we're saying that suicide contagion exists and that clusters exist, that isn't the same, that doesn't support then, the idea that people sometimes have that then they're afraid to ask about it. Absolutely.
Right. I think asking within a clinical or an interpersonal setting is very different than the kind of public messages or what goes out.
Exactly. Right.
University communication.
And there's a question related to this, which I think, again, is really worth emphasizing, a question about gatekeeper trainings, which in many cases are sharing facts and figures about suicide. And the questioner is asking whether, based on what we're saying, there is a suggestion not to mention that suicide is the second leading cause of death for college students. And I think what we've all been saying is that media and news reporting to a lay audience is very different from academic or educationally oriented settings in which you obviously need to share details and data and information in a much more expansive and deliberate kind of way.
Yep, and I just want to expand on this. This is Kerri, that there's research that shows that the general public already knows that suicide is a problem, and what they know less about is how to prevent it. So we're really, when we focus on the statistics, that's when we're missing opportunities to really share what are you going to be able to do about it. And your gatekeeper training efforts are going to be that effort of what are you going to be able to do to respond. And I'm glad we were able to clarify that, certainly using statistics are going to be important when you're talking to key stakeholders or senior leadership to help convey how important suicide prevention is. But again, if the public already kind of knows that this is a problem, we want to instead focus on those messages of hope, recovery, and what you can do to help others that have been seen to help be protective.
So it's important, again, to recognize that these guidelines are a series of guidelines. You need to think about the context and the setting and the balance of these things. That there's nothing here that's an absolute, but you really need to become sort of familiar enough and understand the thinking behind these principles enough to be able to work with this information in different kinds of settings. Well, we're now at the top of the hour, and it's been a really packed hour and a half with a tremendous amount of information and conversation. So what we would do now is take about a half-hour break. We suggest that you keep the computer, the slides open, and just as a reminder, the slides, the PowerPoints will all be available to anyone who's registered. I think we'll be planning to send them out, and then they will be on the SAMHSA, SPRC, and JED Foundation websites, along with the audio of this full webinar once everything is processed properly. So you don't need to worry if you missed something. Again, the questions, there were many questions we couldn't get to. We'll try to get back to people as much as possible. If there are other technical questions that come up, we'll be able to share links and information going forward. So again, please keep the webinar open on your computer screen. If you want to put your phone on hold or just stay on, you'll hear music for the next 30 minutes or so. This will give everybody a time to take a break and just catch up on whatever they need to, and we will be reconvening for part 2 in just about 30 minutes. Thanks for joining with us for this important webinar.